Good morning, everyone. Welcome to the Cancer Center seminar series. Today, I'm delighted to host Dr. Rana McKay from UCSD. Rana went to medical school at the University of Florida and then residency at Johns Hopkins Hospital, where I first met her around 2010. Followed by a medical oncology fellowship at the Dana-Farber Cancer Institute and Harvard Medical School. And I think you were assistant professor there for a few months before you were recruited to a UCSD around 10 years ago, 2016 or so. Rana McKay is currently a professor of medicine, urology, and radiation medicine at University of California, San Diego, as well as the Associate Director of Clinical Sciences at the Moore Cancer Center and the co-leader of GU Medical Oncology. There's a long list of other leadership positions that she has held, but I'm just going to highlight some of them. The NCI Renal Task Force, the NCI Prostate Cancer Task Force, the NRG Cooperative Group Medical Oncology Co-Chair, and the Renal Cell Carcinoma Leader, and also a former member of the NCCN Prostate Guideline Committee, and finally, American Society of Clinical Oncology, ASCO, a nominating committee. So on a more personal level, Rana is one of those amazing people that has actually made practice-changing contributions, not just to one, but two cancers. And most GU medical oncologists like myself, we only get good at one thing. In my case, it's maybe prostate cancer, but Rana became very good at two things, renal cell carcinoma and prostate cancer. And in fact, up until yesterday, I was not exactly sure what she was going to talk about. Initially, she had wanted to speak about renal cell carcinoma, but I got a text from her on the weekend asking whether she can change her title from renal cell carcinoma to prostate cancer. And of course, I allowed her to do that, but we have not changed any of the internal advertisements. So her talk will not be about renal cell carcinoma and will be about prostate cancer, where she will talk about a very unique angle, actually, which is the neoadjuvant space. In other words, the pre-surgical space. And this is an interesting space because it's a window of opportunity. This is an area where we can do a biomarker-driven or pharmacodynamic studies before and after systemic therapy. And of course, it's also a place where we could change the landscape of clinical care because, believe it or not, in prostate cancer, unlike virtually every other solid tumor, we do not have any FDA-approved indications for neoadjuvant therapy or adjuvant therapy in the prostatectomy setting, which actually blows your mind if you think about how many other cancers have adjuvant therapies. She's highly prolific. As of PubMed search this morning, she has 377 publications, and about half of those are in renal cell and the other half are in prostate cancer. And she has been able to do all of that despite being a mother of four beautiful children between the ages of about 5 and 12, and also has a working husband who is a lawyer and works, is it the FBI or the CIA?
Not to be disclosed, you know?
FBI. She can't say anything more about that. So it's my great pleasure and honor to introduce Dr. McKay, and the floor is yours.
Thank you. Emmanuel, thank you so much for that kind introduction. It's too much, and it's actually been wonderful working and collaborating with you and the group here over the many years. So sorry, I'm giving you a talk on neoadjuvant prostate instead of kidney cancer. There's so many cool things happening. I just could not contain myself. And I think hopefully as the year unfolds and new data get presented at ASCO, you'll hopefully find this to be useful. Here are my disclosures. So first, to start off, local prostate cancer is a very common cancer. As you all know, it's the most common cancer among men in the United States. Most patients present with localized disease, but a subset of those individuals, 15%, have high-risk disease, and the risk of those patients actually dying from prostate cancer is higher, I should say, based off of their PSA, Gleason score, stage, and various high-risk features. When we think about the paradigm, and Emmanuel chatted a little bit about this, there's the paradigm of surgery, and then if somebody recurs, giving radiation and hormones, or you can just start somebody out with radiation and hormones. And those are the two paradigms for people who have localized prostate cancer. And that paradigm for surgery, followed by, adjuvant or salvage, I should say salvage radiation or ADT, has not changed in decades upon decades upon decades, even though there's been a lot of advancements for people with advanced disease. And so the question is, can we use hormonal therapies or other novel therapies in the perioperative setting to improve outcomes for patients that are destined to relapse from their prostate cancer? And neoadjuvant treatment is the standard of care for breast, rectal, bladder cancer. It's really revolutionized the treatment of these other solid tumor malignancies. It has the propensity to downstage localized disease and reduce and delay post-surgery treatment. And I think the beauty for myself and probably many of you all in the room is that it actually provides this window of opportunity to provide an in vivo assessment of response to treatment. We know that ADT has been the backbone of therapy in prostate cancer. I think this slide is in like every single Grand Rounds prostate cancer talk that you can imagine, based off of the work of Huggins, and awarded the prize in 1966 for their discoveries concerning the hormonal treatment of prostate cancer. And actually, there was another Nobel Prize that was awarded to Andrew Scally for their work on discovering LHRH and FSH, which subsequently ended up resulting in a lot of the therapeutics, the LHRH analogs that we use to treat prostate cancer. And while ADT remains the backbone of treatment, there's been a ton of evolution with additional more potent hormonal therapies that have entered into the treatment landscape, immunotherapies, radiopharmaceuticals, targeted therapies, the PARP inhibitors, pembrolizumab. And these therapies have moved from the metastatic setting, late stage metastatic setting, and slowly kind of creeping into the localized setting, but nothing at the present time being given perioperatively. So we're going to talk about a series of studies that have began to shed some light on how do we optimize perioperative use of these treatments to improve outcomes for patients. I just want to highlight just mechanism of action. Right now, there's 4 next generation. I shouldn't even say next generation because, some of them are off patent now, but androgen receptor pathway inhibitors, enzalutamide, apalutamide, darolutamide block the androgen receptor with significant, binding potency, but they also prevent translocation of the androgen receptor into the nucleus and prevent the androgen receptor from binding to AREs in the promoter regions of various genes. And then you have abiraterone, which actually decreases testosterone production made in the adrenal gland as a sub-17 inhibitor, and it also works intratumorally as well. So as we step back and talk about the neoadjuvant clinical trials that have been conducted in the 1980s and 1990s, a series of neoadjuvant studies were performed and looked at LHRH analogs with or without first generation anti-androgens for patients with localized disease. The majority of patients that were enrolled on these trials were low risk. They were primarily done to decrease the positive margin rate of doing radical prostatectomy. They did not have systematic pathology review. There was limited long-term outcome and long-term follow-up. And the field kind of, stepped away from that paradigm because largely the way these studies were designed. And then with the advent of these newer agents, there's been a series of more contemporary neoadjuvant studies that have looked at more potent androgen targeting, actually included a much higher risk population of patients that were really actually needed treatment intensification. There was an approach for systematic centralized pathology review and then ongoing long-term follow-up. So we're going to go through a series of some of these studies and the lessons learned and how it can potentially shape the future for localized prostate cancer. So the first study that I want to highlight is from my mentor, Mary Ellen Taplin, who's just been a mover and a shaker in this field. And this study was published more than a decade ago, and it was a very smartly designed study looking at 12 weeks versus 24 weeks of neoadjuvant abiraterone. And this was right around the time that abiraterone had actually, even the study was conceived even before the FDA approval of abiraterone, when the large phase 3s were actually happening. But it randomized patients with unfavorable intermediate or high-risk disease to receive abiraterone Lupron for 24 months, or to first receive 3 months of Lupron, and then for the first 3 months, and then the second 3 months receive the combination. And they all went on to get radical prostatectomy. And the primary endpoint for this trial was looking at 12-week intraprostatic hormonal levels. And this trial also provided insights around, well, what's the right duration? Should we do 12 weeks? Should we do 24 weeks? How long of a neoadjuvant course does any one given patient need? And so what we demonstrated in the context of this trial was actually, with 12 weeks of therapy, the addition of abiraterone resulted in more dramatic declines of intraprostatic testosterone and DHT levels. And when we actually look at the 12-week, PSA levels, it was around 1 in the LHRH arm and around 0.1 in the LHRH abiraterone arm. And interestingly, when you look at the 24-week levels, the PSA levels, they were pretty comparable actually between the two arms. The PATH CR rate and PATH minimal residual disease, and minimal residual disease here was just defined as the cross section of the largest tumor that was seen in the prostatectomy bed. It was 4% combined PATH CR MRD rate, with only 3 months of abiraterone during that 6-month course, compared to 24%. And so from this study, longer was better than shorter. And so then the series of trials evolved to basically look at 6 months, because we really weren't driving down intraprostatic hormonal levels to as low as we can get them. So also around this time, enzalutamide was also being tested in late stage disease. Enzalutamide, as I said, is an androgen receptor antagonist. And another question that was had was, like, do we need the LHRH backbone? How is enzalutamide going to perform by itself? And this is actually so relevant now with EMBARK, because we've got, enzalutamide monotherapy. So this study, it was led by Bruce Montgomery, and also the team at the Farber were involved, enrolled a similar patient population, unfavorable, intermediate, high risk. And patients here were randomized to neoadjuvant enzalutamide dutasteride, which is a 5-alpha reductase inhibitor that prevents the conversion of testosterone to DHT, plus Lupron, versus just enza monotherapy. And the primary endpoint here was pathologic response. But interestingly, in their path response, the former study I just mentioned defined it based off of 5 millimeters of tumor left behind. This study had a little bit more stringent definition of 3 millimeters of tumor left behind. And it, even though the eligibility criteria were set as they were, 80% of patients that enrolled had high-risk disease. And what's really interesting is the enza monotherapy had a PATH CR MRD rate of 0%. And I think this really helped us move away from just enza mono or omitting the LHRH analogs in this context. The PATH CR rate, MRD rate with combination was around 17%. So as we evolve, all of us had this question at this time. And now in hindsight, as we've seen data kind of emerge, this question is still probably relevant, because I think we have to work out the PK of these drugs. But we had the question of, well, can we combine these two? Can we combine Abi and Enza? And are we going to have a more enhanced therapeutic effect if we have a testosterone inhibitor, synthesis inhibitor with an antagonist? And so this study, again, took very similar patient population randomized to Abi-enza-Lupron versus Abi alone with Lupron, followed by radical prostatectomy with a primary endpoint of past CR minimal residual disease. And I have to say, in the series of these trials, there was very systematic assessment of the path response. Everything was centrally reviewed. There was criteria around how the prostate had to be sectioned, and the specimens kind of centrally evaluated. So it wasn't just, what your local pathologist called. There was a lot of tissue changes that happened from the hormonal therapy. And we're going to get into that just in a little bit. So in the context of this study, we actually saw potentially a signal of a slightly higher path CR MRD rate with the combination. So 30% here with the combination compared to 16% with just enza-Lupron alone. And so additionally, in the context of this trial, we started to learn some biologic insights because we did ERG staining, P10 staining, and identified that none of the responders, basically none of the responders had ERG positivity or P10 loss, if you will. So I think started to learn this is just IHC data. Building on this, so a lot of ways we're kind of like looking at all of this data. So there's a signal potentially that Abi-enza may elicit more dramatic upfront responses, but so far everything has been upfront. We've not done anything out back for those patients that may not necessarily have a good response. And so building on that backbone, we designed this study, which was a two-part study, which had a perioperative, a post-op, a pre-op component, looking at Abi, apalutamide, and Lupron, then radical prostatectomy. But then for those patients who did not have a good response, doing additional therapy for up to 12 months in part 2. So interestingly, this study was basically to help inform the design for Proteus, which is the large phase 3. And Proteus initially had an Abi component embedded. And actually, after the results of this trial were reviewed in combination with the prior study, the decision was made to remove abiraterone because in the context of this trial, we actually did not see more dramatic responses with Abi-APA compared to just Abi alone, 20% versus 22%. And, taking this all together, the abiraterone component from Proteus actually was removed. That trial was amended, and nobody will ever remember that in the history books. So in the context of this study as well, we started working with our imaging team and embedded multi-parametric MRI pre-op, prior to therapy initiating and then prior to surgery. And this is just an example of, somebody's pre-neoadjuvant therapy MRI. You can see the different, functional series, T2 W-weighted imaging, ADC, DWI, and the DCE. You can see kind of this tumor identified in the prostate in the pre-op imaging that's essentially gone on MRI imaging. Interestingly, when you actually look at the path, it was a very poor correlate for MRI. So we actually did not find a strong correlation like is done with rectal cancer and maybe some other tumors with MRI findings and pathology. This was a case of, as we look at these like invasive carcinoma with an intraductal component, tumor was AR positive, had P10 loss, was ERG positive. And so I think there's still work to be done in the MRI space as we learn more and these images advance. So now the postoperative component. And this is why, it's not to say that adjuvant studies haven't been done in prostate cancer. There's been a lot of adjuvant studies that have been done or attempted to be done post-prostatectomy. They've universally failed because patients don't want to be randomized to postoperative therapy when their PSA is undetectable. Most studies close down because of a lack of accrual Even in the context of this trial, the part 2 had a co-primary endpoint. The first endpoint was feasibility, which we barely scathed by because 30% of patients actually declined at the adjuvant therapy. But we did actually pass our feasibility threshold. But then when we looked at the 3-year biochemical progression-free survival rate based off of the intent to treat analysis, there was no difference between the arms. But if you look at the protocol analysis, the people that actually did receive the adjuvant component, they did better. And I think this is something that we're going to have to contend with as new studies get designed and there's a post-operative component. How do you handle that? Okay. We also demonstrated that the responders do well, whether they received adjuvant therapy or not, and the non-responders do poorly, whether they received adjuvant therapy or not. But in general, especially for the non-responders, this is where we kind of see the curves kind of separating, and the patients that received an additional 12 months of therapy, even if they didn't have a great pathologic response, they did seem to do better with post-op treatment. The other component of these studies was we actually looked at testosterone recovery, because that's a huge thing, right? For patients getting, perioperative treatment, they're getting hormonal therapy, they're getting intensified hormonal treatments. Like, are they actually going to recover? And in actuality, the majority of patients do recover. And, all of these patients had 6 months of intensified neoadjuvant therapy. And in the observation arm, 95% of those individuals recovered their T. And we defined that as a testosterone that was greater than 200. And the median time to recovery was less than 12 months. So, most of these men with localized treatment are going to recover. In the group that actually got the Outback treatment, 81% had T recovery. I think that's good to demonstrate. The other piece to this, okay, so you're telling me all this stuff about pathologic response, like, does it correlate with anything significant down the road? And so we started to do kind of a pooled analysis of everybody who had a pathologic response and what their outcomes were. We did 2 pooled analysis. The first one was in the first series of trials that were conducted with 72 patients. The second one, even though the median follow-up was 3.6 years, we increased the sample size because we added one of the newer studies. And you could see this is looking at BCR rates, that for those individuals that had a pathologic response, whether it be MRD, defined by that diameter, length of tissue or length of tumor that was remaining, or a true path complete response, they did fantastic. In the first analysis, not a single one of those patients recurred. In the second analysis, I think 1 or 2 patients, you can see that one little tick right there, recurred. And so it did really actually seem to correlate with outcomes. So as we think about pathologic response and what's the right path endpoint, as these specimens were getting reviewed and looked at, and we were kind of communicating with the pathologist, to hit a path CR was actually quite hard. And across all the studies, it kind of hovered right around 9 to 10%. Like, regardless of what you did, it kind of hovered right around 9 to 10%. And really what we were adjusting with the intensified therapy was the proportion that were MRD. And we very crudely initially defined, this is Mary Ellen and Rosina and all kind of like, the movers and shakers in this field, just very crudely defined it as just less than 5 millimeters of tumor left behind in the radical prostatectomy specimen of the largest target that was seen. And you can get a sense that there's some arbitrariness to that. Like, why 5 millimeters? Like, why not 7? Why not 3? We looked at 3 with Bruce Montgomery's trial, and, one, it was really hard to call. And then, not to say that the rates were lower, it was more of a matter of actually being able to systematically, consistently call the 3 millimeters. But we were also learning is like, you could have a very dense tumor that was still 5 millimeters, or you could have a tumor that was just not as dense. Like, there's a lot of scar, maybe there's, a couple of cells here, so the cellularity differ. So learning from our colleagues in the breast cancer space, we started to evolve and integrated into the Abby-Enza study, this concept of residual cancer burden that was basically assessing tumor volume that was adjusted for cellularity. And so you can see the formula there at the bottom. And that seemed to be, not to say something that could be more ascertainable for actually being able to assess what was actually happening inside the tumor. So then the other question is, we've got these endpoints. How do they correlate with long-term outcomes? And one of the biggest things with prostate cancer that's been the Achilles heel of drugs moving into the localized setting is, how do we identify endpoints that we can actually hit on and not wait 2 decades for overall survival to read out on a localized trial? So, this was the ICE-CAPTCH initiative that was led by Chris Sweeney and others, looking at MFS, and the surrogacy of MFS was overall survival. And this really helped establish MFS as an intermediary endpoint for regulatory approval for studies in the localized setting or BCR setting. Now, this was all predicated on conventional imaging, and this is now going to evolve with PSMA PET imaging and going to evolve even more. We're working with Chris and David Einstein at Beth Israel on the concept of treatment-free survival or freedom from clinical detriment, which is so important for our patients. But this established MFS as, we have an intermediary endpoint, but what's the correlation between RCB and MFS? And this analysis, it didn't just look at RCB, it also looked at past CR MRD rates, and there seemed to be a correlation between residual cancer burden and actually MFS. And I think as these studies evolve and we think about regulatory endpoints and surrogacy of path surrogates with MFS, potentially RCB could be a better path endpoint. It seemed to better correlate with MFS than actually MRD itself. So here's kind of a summary of all of those key studies that Mary Ellen and Bruce and many others led. I think this is, I was telling Emmanuel that that first study of Neo-Abby-Enza, I should say, not the first one, but the Neo-Abby-Enza was a study that I wrote with my mentor, Mary Ellen, when I was at the Farber and took to Vail, and Angelo DiMarzo was helping with the path, and it's great to see these things come to light. But they helped inform Proteus, which is a large randomized phase 3 study looking at neoadjuvant Abby ADT versus placebo ADT. And there actually is a sub-study with a RP alone arm for the European regulatory authorities. And this is going to be a game-changing trial when it does read out. Per clinicaltrials.gov, it's supposed to read out this year. And I think that this has the potential to be practice-changing. This trial enrolled very high-risk patients, even beyond what we were enrolling in our localized studies of unfavorable, intermediate, or high risk. They really had to have high volume, high-risk disease. So you couldn't just get on this trial with a little bit of Gleason 8 from your biopsy. You really had to have high-risk disease. And I think the correlatives that we're going to learn in the context of this study are going to be just tremendous. And I think this study, what another really unique aspect of it is it actually has a co-primary endpoint of past CR MFS. So I think it's going to pave the way for additional studies, and I'm going to highlight some that are going to embed pathologic endpoints that could have a strong correlation with MFS. All right, so let's sort of dissecting out the biology even more. I gave you a little bit of a hint from the Abby-Enza study where we did the IHC for ERG and PTEN, and trying to dissect out, well, who are these responders and who are these non-responders? And this was an analysis that we did on the baseline biopsies of patients that were exceptional responders, either had a past CR, MRD, or were non-responders, meaning they were PT3 at the time of surgery or had nodal involvement. And you can imagine that this work was really quite difficult because you're dealing with baseline biopsies, identifying, clusters of disease in the baseline biopsies, multi-regional whole exome RNA sequencing. And I think this recapitulates some of the findings that we've observed now in the metastatic setting is among the exceptional responders. There was an enrichment for SPOP. You know, the numbers are small, so this is obviously just kind of for hypothesis, but there wasn't a single patient that was an exceptional responder that had a TP53 alteration or had P10 loss. And we saw the opposite effect in the non-responders. There was no SPOP, and there was an enrichment for P10 loss, TP53 that was seen. And just recently, we are starting to see some evolution of more elegant adaptive studies, neoadjuvant studies being done. Martin Gleave has been leading the GUNS trial. It's a genomic biomarker selected umbrella study in the neoadjuvant setting. It enrolls high-risk patients. And it's interesting. So it's 6 months of therapy, but the first 2 months, patients are just on Lupron APA. And during that time, their baseline biopsies are getting sequenced so that a decision can be made into what protocol they get randomized to. And so patients are on therapy, so they're okay, they feel good, they're on ADT APA. And then based on what they have, they're allocated into a specific arm. So we're going to go through subprotocol 1, which was no actionable alteration, and the recent data that were just presented from subprotocol 2 with docetaxel. And then there are others for the DNA damage repair and then mismatch repair. As you can probably imagine, the rate of enrollment for those arms or those cohorts is going to be much lower just because of the lower frequency of those alterations. And the primary endpoint here was PASS-CR MRD based off of those same definitions we were using. So for subprotocol 1, for patients that didn't have any alterations, they were randomized to ADT plus APA plus minus abiraterone. And in this group of individuals, there actually did seem to be a benefit of adding in the abiraterone. You can see the PASS-CR MRD rate of 48% versus 13% in this subprotocol, okay? And then interestingly, at GU ASCO just this past February, Martin presented the data for subprotocol 2. And to get onto subprotocol 2, you had to have one of the 3 tumor suppressor gene alterations positive in your baseline biopsy. And in this group, patients were receiving ADT-ABI plus minus DOSI. And what's striking is the PASS-CR MRD rate with just the doublet in this group was 0. Again, similar to kind of what we saw in the earlier studies, but 37%, and actually it's even a little bit higher because this, I think it's like 41% when we look at the triplet, because when you factor in the PASS-CR with the addition of chemotherapy. And so I think this opens up a little bit of a window around, could there be a role for perioperative docetaxel? And here's sort of the summary of subprotocol 1 and subprotocol 2. And I think we're going to learn more about the underlying biology here. So that brings us, I just want to go back and reminisce on the PUNCH trial. And for those of you who may or may not know, the PUNCH trial was a trial that was conducted through the cooperative group, looking at neoadjuvant docetaxel for 6 cycles with an LHRH agonist, followed by radical prostatectomy versus radical prostatectomy alone. And I think this trial and many others that have really kind of pinned down, like, it's really important that your primary endpoint is the right primary endpoint. Because if the primary endpoint is not the right primary endpoint, you could have a winning regimen or a winning trial that'll lose. And I think this trial recapitulated that. So the primary endpoint for this trial was 3-year biochemical progression-free survival. And there was no difference between the 2 arms. And the main reason there was no difference between the 2 arms is post-protocol management was really flawed in the context of this large cooperative group study that was getting conducted across community and academic sites across the US. So on this trial, patients had to wait until their PSA hit 0.2 and was confirmed, before they were permitted to receive per protocol therapies. But many patients and many physicians did not want to wait until they hit that 0.2. They received off-protocol therapies before they had an event. And so the censoring rate in the context of this trial was 40%. 40% censoring because somebody acted on a PSA when it was like 0.12 instead of waiting until it got to 0.2. And this killed the trial because even though the primary endpoint was negative, the hazard ratio for OS was 0.61 with a confidence interval of 0.4 to 0.94. Like if this trial had been powered on overall survival and enrolled a little bit more patients, it would have been a positive study. But nobody even thinks about this study anymore. So, and this was the rightly done study because the comparator was surgery. The comparator was surgery alone. It took forever to accrue this trial. It took 15 years to accrue this trial. It's a shame because, I think there was not to say a winning formula here, but there was an opportunity I think that was missed and flawed. So learnings from Punch, with regards to the neoadjuvant data, we've started to sort of unravel some of the underlying biology. There wasn't a lot of pathologic responses that were actually observed. 3 of the 52 patients from this sort of focalized analysis actually had residual or small volumes of residual cancer in the radical prostatectomy specimens. And then you can see the enrichment of alterations after neoadjuvant docetaxel. So those tumors that remain after docetaxel are very aggressive tumors. And this work has been led by Nisha Beltran. And this is really quite interesting, looking at just tumor fraction in the RP specimen. And just tumor fraction alone was really associated with negative outcomes. So anyway, building on this, I'm going to keep moving this sort of tail end of the study. So this brings us to ADAPT. So ADAPT, seeing where the field is going with Proteus, that's likely going to read out. That's maybe a game-changing study. There's going to need to be a platform for us to test novel therapeutics in a very seamless plug-and-play way. Because honestly, there's too many promising agents, too many combinations to test in our traditional fashion. And for those individuals that have very high-risk localized disease that are destined to relapse, that have a relapse rate of greater than 80%, we need to do better. And so this is sort of the design for ADAPT. This study is now being done through the PCCTC. It's a randomized open label phase 2 platform trial that's enrolling patients with Proteus high risk, also allowing individuals with oligometastatic disease to enroll. There's a continuously enrolling control arm with ADT, APA, or DARA, understanding where the field is going with Proteus, with an opportunity to slate in additional investigational arms. Primary endpoint pathologic response, which is basically residual cancer burden, and a key primary endpoint of biochemical progression-free survival. This is not supposed to be the end-all trial, but rather the signal-finding trial that will then take the agent into phase 3. So the ADAPT will be successful if many agents end up moving on into phase 3, and we shut down arms that are not, that aren't successful, and we advance arms that are successful. A little bit about, I'm going to shift gears because I'm going to talk about the first ISA for ADAPT. So human kallikrein 2 encoded by the KLK2 gene basically is a peptidase that functions in semen liquefaction and sort of degrading extracellular components within the tissue architecture. It's androgen regulated, and we've done some elegant work that Emmanuel has also been involved with and others, looking at its expression in adenocarcinomas versus neuroendocrine and across prostate tumors. It's highly expressed in primary prostate tumors. The beauty about KLK2 is that it's just so specific to prostate. It's not really expressed anywhere else. We don't see it expressed in the liver or salivary glands or intestines or other parts. It's very specific to prostate. We demonstrated strong correlation between KLK2 and KLK3, which is basically PSA. There's about 80% homology between the sequences of KLK2 and PSA. We actually did demonstrate, because as we're thinking about slating in this agent into the neoadjuvant setting, we wanted to understand how ADT impacts KLK2 expression. And while ADT or ADT and an ARPI decline expression, there's still pretty high expressions, high expression even after receipt of ADT or ADT with an ARPI. And these tumors seem to be molecularly distinct, enriched for SPOP, decreased TP53, P10RB, and tumors that express high KLK2 seem to be associated with improved prognosis. This is work that's been led by the MSKCC group, basically codifying HK2, which is the protein, as a therapeutic target for both radioconjugates, bispecifics, and even CAR-Ts. And here's the initial data of pasritamig, which is a KLK2 targeting TCE. In prostate cancer, there's now multiple phase 3 trials in the CRPC setting, looking at this agent either as a monotherapy or in combination with docetaxel. And what's striking is the very low rates of CRS, and I think that's largely because the target is very specific to prostate. 9% CRS rate, all grade 1. Mainly it was just fever. Nobody received tocilizumab. And so just understanding the target, this is a beautiful agent to slate into the localized setting. And so this is the first ISA for ADAPT. We're waiting for the final signatures on the contract to go through. It's been many years in the making. This is what I do at all meetings, is try to find partners for this platform study. And happy to work with you all on that. But this will be the first arm, is pasritamig ADT plus apalutamide. And we're excited about that. And there's a lot of emerging targets that could be targeted in the context of ADAPT beyond KLK2, whether it be PSMA, STEAP1, STEAP2, B7H3, TROP2, and others. You all have done elegant work with B7H3. And here's sort of the neoadjuvant study that was recently published in 2023, 32 patients that were enrolled, monotherapy without ADT as a backbone, with a PSA 0 at 1 year of 66%. So there's clearly a signal here, and it'd be great to think about slating in ADCs into the context of this study. And then elegant work that was recently published from MSKCC, Matt Dallos, a neoadjuvant FC enhanced anti-CTLA4, and activity in the neoadjuvant setting. We've also seen some interesting work from the Australian group on the lutectomy trial, neoadjuvant lutetium 617. We don't really have too much with regards to path endpoints. The primary endpoint was just PSA response. There was no ADT that was utilized in the context of this study. It was just lutetium by itself, but seemed to have some signal. And patients, so seem to have some signal. Lastly, I want to highlight is our Neptune study. We know that about 6% of individuals who have high-risk localized disease are going to have DNA repair alterations, germline DNA repair alterations, and these patients do quite poorly. And so we have a study ongoing of olaparib ADT prior to radical prostatectomy for patients that are HRR positive, and also SWOG S2210, led by Heather Chang, is enrolling patients through the cooperative group of carboplatinum, prior to radical prostatectomy for patients that are germline BRCA1/2 mutated. So that takes me to the end of the talk. Patients with high-risk prostate cancer are really at increased risk of death from prostate cancer, and we need to do better for these individuals. I think the traditional paradigm of drug testing is too slow, and for us to really make a dent in the outcomes for these patients, I think we need to do more. Neoadjuvant intense ADT is associated with pathologic responses, and these responses seem to correlate with long-term outcomes, progression-free survival, MFS, and large phase 3 trials are currently underway that I think are going to change the field. And hopefully this opens up the door for additional therapeutics in the localized setting. So I will end there.
I have questions, or I have microphones for anyone with a question.
right. Great. Rana, great talk. And this is great to see all this work. And, it's just, I'm trying to learn as quickly as I can as a basic scientist more so. And my question is, how do we think about this, for example, with the work that's done with radiation oncology? Because we see a lot of trials there where they're thrown in thrown in using ADT as well, and they're seeing some benefits with some biomarker selection as well. How do we eventually decide what is relevant? And then I'll just ask another question, but for my personal interest, like for example, how do we think about decipher testing, for example, using that to risk stratify patients as well?
Yeah, very good question. So I don't think that the radiation trials are distinct from the surgery trials. You all know this in the clinic. There are some individuals those that are on the far end of the spectrum, very high risk, that it's unlikely that surgery is going to do the trick for them. They can definitely have radiation and surgery or radiation and hormone therapy down on the back end. But it's a very personal decision for somebody to decide to do surgery or somebody to decide to do radiation. And I think many of these individuals probably multimodal treatment. And so the paradigm hasn't shifted if a man were to decide, well, I want my prostate removed. So I guess that's how I pose that, you know what I mean? So I think it's very personal. And for those high risk individuals, surgery alone is not going to do the trick. And is there a way that we can improve the outcomes for those individuals? I think Decipher is great. I think the Artera AI tests are great. The other beauty also about Decipher is you also get the AR signaling score, you get the P10 sensitivity, you get all the RNA data. We are working on actually for Punch, doing the Artera and Decipher interrogation from those baseline biopsy samples. So that will come in the future. It's just been incredibly delayed with the cooperative groups, but I think it'll be helpful.
So one of the challenges in the field being a translational scientist is getting access to longitudinal samples. And so the trials that you just described that could potentially be practice changing is going to really revolutionize the availability of samples and what we can do. So how do you envision in the future teams being organized around these trials and the obtaining and the analysis of these samples? Because we've been quite siloed within our fields of cancer, or prostate cancer, and
yeah,
I imagine there'll be a lot more integration going
Oh
forward.
my God, there has to be. I mean, I think every single one of these studies needs to have a pathology lead, a translational lead, probably an imaging lead, and all kind of coming together, because it's not like it's a total team sport. And so I think that's the beauty actually about it is, there's no way to do any of the neoadjuvant studies if you don't have a champion. So I do think that it's going to allow for that cross-pollination and people coming together. And but the thing about it though is it's not one of these things that gets done on the back end when the trial is done. It has to happen like a priori as you're like designing things. Okay, how are you going to section the tissue? How is it going to get processed? How is it going to go to my lab? I remember one of the hardest documents I ever had to write was, because it was the first time I'd ever done it, was the correlative lab manual for the first neoadjuvant study I ever wrote. Because I was like, okay, I need to get data from 20 different people to like write this document. Like, the pathologist, how do you want? And then, okay, what do we need to do from get from Ellie's group? And what do we need from the MRI group? And the specs on the MRI, how do we make sure that all sites are doing the MRI in the same kind of way and running the same specs on it? Like it was just painful to have to put it together. But that's what has to happen. It has to happen a priori, And even though you may not necessarily have the funding for the analysis, like embedding the resources to collect things in the appropriate right way so that you can apply for downstream funding is the key, right?
Yeah, because you never know if the hypothesis will be present at the time
Right.
that the samples are being planned,
Yeah.
or if maybe 2 or 3 years later, you'll discover something that then you have to find the right resource to
Yeah.
go back and try to see whether you were right in.
Scott, are you involved in ADAPT at all? I don't
No.
know if you are. And so Josh and Andy are leading our biomarker. So we have a steering committee and basically four groups. There's like a protocol committee, there's an arms selection, a biomarker, and then a data committee, basically. But Josh and Andy are leading biomarkers. So we kind of harmonized against what are the core elements that every arm needs to have. And then there'll be additional things that we may add in depending on that partner. For example, like KLK2 IHC for the PATH study, or, you know, B7H3 if that were to go through, or methylation signatures for EZH1/2 inhibition. So we should get you plugged in. Like, it's an open group, open network, and happy to have you join. Yeah.
All right, we have a question from Doug Yee on our virtual audience.
Hi.
Yep, go ahead, Doug.
Thanks so much for the great talk. I'm a breast medical oncologist and work in I-SPY, and I think if you rub shoulders with your breast medical oncologist, UCSD is a big I-SPY
Yes.
accruer.
Yeah.
One of my jobs, and it has very similar features to ADAPT. One of my jobs on the trial is to co-chair the agents committee, so we have the responsibility of bringing new agents in. But the question is, we've always viewed I-SPY as a standing platform phase 2 trial to look at activity of an agent in the neoadjuvant space. But we're being increasingly asked by sponsors, what is the regulatory pathway for my drug? To rephrase that question, what surrogate markers can you test in the neoadjuvant space that the FDA will say, yeah, that's good enough to correlate with event-free or disease-free survival, because we, the FDA, want to know that. So what we're trying to do a combination of RCB and ctDNA in addition to correlate with long-term outcomes. But it's a tough road, and I think companies are getting less interested in bringing a drug into the neoadjuvant platform unless they see a clear regulatory pathway. So I just wanted to think about, what are your thoughts in your trial on how you're going to address that?
No, I think it's a really important question. I think, honestly, we're riding the coattails of Proteus, which has the co-primary endpoint of PathCR MFS. And so the hope is that in the context of that study, some degree of surrogacy will be established in a 2,500 patient trial, if you include the sub-study, for path response with MFS. And that'll open up the opportunity for utilizing a pathologic endpoint to make a decision around phase 3 investigation. I mean, this is not, the path endpoint is not the registrational, I don't think it will fly in prostate cancer. That a path endpoint alone is going to be the registrational strategy. I think it's going to take some time before we design a large phase 3 where a path endpoint alone is going to get a drug approved. I think it's going to have to be path MFS. It's going to have to be, I think path OS is very hard because these patients live so long. I think the other complexity for us is PSMA PET imaging, which has thrown a wrench into how do you actually call MFS, because MFS is an evolving thing. So, but yeah, actually a lot of lessons learned from our breast community, which was decades ahead of us. And
yeah, I just, one of the things, just as a point of information that you guys might want to consider. So the FDA is making us, so to speak, go find independent data sets that show that, what we've shown in I-SPY, which is roughly 3,000 patients, also works in another data set. And that's hard to do. That really is hard to do, especially for the path responses. Or even for MFS, it's really hard to do because not necessarily everybody is tracking that. So
yeah,
it's just, hopefully you can engage your colleagues internationally to really crack this problem, because I think the idea too many drugs, not enough time is exactly right.
And I actually think there's going to be a tremendous technology opportunity here. And I'm hoping that it could be shepherded by our industry colleagues because it's also very costly. But you can imagine that this is a ripe opportunity for AI to be involved, like actually calling out residual cancer burden, like to expect a pathologist during their routine clinical care to read out on RCB. Like they're going to take a case that would take them, I don't know, 15 minutes to review, 20 minutes to review, and now they have an hour and a half to 2 hours to review that case to read out on RCB. That's not going to fly. And so I don't know what you all have been doing in the breast space, but there's tremendous opportunity to leverage, AI in that readout. And I think J&J has been doing a lot of behind the scenes work in the context of Proteus around that specific space.
Yeah, no, agree, thanks. As you know, the pathologists are very skeptical of AI. They don't want to.
Yes.
Yeah. So you got to get somebody who's a believer on the pathology side.
Yeah.
All right, do we have any other questions?
Yes.
Oh, got one down front.
Nice
Yep.
talk. I have one basic question. So one of your data shows that the MRI and the ISC is not really correlating. So I do a basic science research. It's confusing me. Like as a clinician, I mean, based on this kind of data, what kind of decision you make? The patient goes to chemo, surgery, radiation, what?
No, I mean, I think the surrogacy of MRI to pathology is really, I think, just at its infancy. Like it's the MRI, at least in prostate, from what we have seen, does not recapitulate what's happening at the cellular level in the tumor or in the prostate. And so it doesn't necessarily change your paradigm. These patients are still going to undergo surgery, but I think it definitely calls into question a strategy that may be being used in rectal cancer where somebody has a dramatic response on MRI and then they can avoid having surgery because you have MRI to say, hey, they did really excellent. I don't need to resect their tumor. I don't think we're at that point in prostate cancer because I think the surrogacy between MRI and path is low. Yeah.
Thank you.
All right, we have one more question from our virtual audience, Anne Blaze. Thank you for a wonderful talk. It is impressive to see all of the incredible work going on in prostate cancer. Can you comment on how you have been working across community sites in implementing neoadjuvant therapy, given these practitioners often see patients in different settings?
Yeah, very good question. I think when I know Proteus was rolling out as a large international trial over 500 different sites, there was a lot of community engagement with the sites, with urologists. I mean, many of these patients aren't even being seen by medical oncologists. They're being seen by urologists, engagement with pathology on just educating around, just the tissue processing components. But I think there's a shifting in enthusiasm around neoadjuvant therapy because of the entire cancer space shifting around neoadjuvant therapy, more so than, probably a decade ago. So, but it does take a lot of community engagement, education. There's actually been like monthly community calls for all investigators for Proteus, just getting everybody on board and making sure everybody knew what to do. So thank you for that question.
All right, great. We are out of time, and let's say thank you one more time to Dr.
Thank you.